Welcome back to another new session where we're going to discuss on the contract issue disorders. If you can see and you can hear me properly, then you can tell a yes or probably a thumbs up must do. Hopefully, I can see a few yes. Cool. Okay, not an issue. So even though rheumatoid arthritis is also a contract issue disorder only, so there is no doubt about that. And the prototypical contract issue disorder, as we wanted to know, is the systemic lupus erythematosus, SLE. So that's what we're going to start with first. SLE. SLE, we know, like it's a strong female predominant disease. In fact, most of the females with reproductive age group are the people who are highly prone to develop systemic lupus erythematosus in the first place. So that's what I'm going to tell first, even though it's a female predominant disease. And I want to tell with respect to age, how this male-female ratio is distributed. Suppose if the patient's age is less than 16, because there are a lot of people who get this childhood sort of an SLE, so if the age is less than 16 years, then the female-male ratio will be approximately 8:1. Still, it's a little high only. The females are the ones who are very commonly affected. But in the age group of 16 to 55 years, the female-male ratio will become approximately 10 to 15:1, which means it's considerably higher. And beyond 55 years of age, the female-male ratio comes to a halt that like around 3:1. So this is going to be the female-male ratio as far as the older people is concerned. So what it clearly tells, so the females in the reproductive age group are the ones who are highly prone to develop systemic lupus erythematosus. As you move to an older age, there is no significant female-male difference, even though still it is common in females. That's why I told in the beginning itself it's a female predominant disease, but still the ratio is actually much lesser in the older age group, the comparatively speaking. And this also brought us thinking regarding one important entity that can precipitate the development of SLE is estrogen. So probably there could be a massive role of estrogen in the development of SLE in females. So, but we still don't know whether that is the factor or there are a lot of other factors that are related to the development of SLE, because we have a lot of evidences to say that many other things are also involved clear-cut in the development of systemic lupus erythematosus. So estrogen could be one of the existential risk factors, but if not the only factor for that matters. But nevertheless, any female in the reproductive age group is actually prone to develop systemic lupus erythematosus. Fine. So as I told you, any autoimmune disorder to develop, you need a background genetic insult, then followed by some environmental and existential factors are needed to develop an autoimmune disease. In this perspective, we're going to talk about a systemic lupus erythematosus. So as far as the genetic background is concerned, there are a few things that are important for our understanding. The first one is the HLA association. Is there any really HLA association? No, like there have been a lot of HLAs that have been told to be involved in development of SLE, like DR4, DQ8, and DR3. Many HLAs have been told, but really we don't know is there any single HLA that predisposes the risk of developing systemic lupus erythematosus. Then there has been postulations with regard to TREX1 gene mutation. TREX1 gene mutation. And again, this is only a speculation. We really don't know whether this has any huge implications in the development of systemic lupus erythematosus. Then third thing is the complement deficiencies. For example, if the patient is having some early complement deficiencies, especially if the patient has some congenitally having some complement deficiencies, especially in the early complement pathway, like example in the classical pathway. So that could predispose the development of systemic lupus erythematosus. We know what is the classical pathway and what is the alternate pathway. Like C1, C2, C4, all these things will come under the classic complement pathway. And your factor B properdin, these are things that come under the alternative pathway, which we'll be seeing subsequently. So classical complement pathway deficiencies, especially the early complement deficiencies, are associated with development of SLE, and it's been clearly proven. And probably interferon alpha related mutations. So interferon alpha pathway related mutations has also been thought to be one of the key features for the development of systemic lupus erythematosus. But nevertheless, none of the genetic components has been concretely proven, except for the fact that complement deficiencies has been surely associated with the development of, in fact, very severe kinds of systemic lupus erythematosus. Apart from that, none of them have been concretely proven. When you go to the environmental issues that can result in the development of SLE, So number one is the virus. So if somebody asks you what is the strongest environmental link or strongest infectious link that has a very important role to play in the development of SLE, it is Epstein-Barr virus. This is one of the strongest infectious link with regards to development of systemic lupus erythematosus. Then silica dust has been thought to play a role, but again, not very sure. At the same time, certain drugs probably has been thought to play a role in the development of SLE, but again, not concretely proven, because drugs that can cause drug-induced lupus erythematosus, clearly have been proven that they do not flare up the SLE if they have been used in SLE. At the same time, they are not associated with the development of systemic lupus erythematosus also in a very clear-cut way. So that's why, again, that's a question mark. And there are some existential risk factors are there. Existential means these are always there. And day-to-day life, you will experience all these things, but only few people will get some issues because of that. So in that, the hormones are going to be the most important, especially with regards to estrogen. We know that females do get, especially estrogen may have a role, but how it really regulates the pathogens of systemic lupus erythematosus, we don't have a clear idea. And then we have the UV rays, because we know majority of the SL-related lesions, especially skin lesions, tend to be photosensitive, and probably we think that that could be the reason why UV rays could play a role and could have a role in the development of SLE. Nevertheless, we have three types of factors. One is genetic, environmental. In the environmental, we have some background existential risk factors that can result in the development of systemic lupus erythematosus. So we really did not have much idea about how SLE develops in the first place. Now we have some idea. You have separate books on SLE pathophysiology alone, because SLE is considered to be the basic and the signature autoimmune disease that everyone should know. So that's why we have separate books on systemic lupus erythematosus. But nevertheless, we have to compress all the pathophysiology in a single way. A single diagram and a single flowchart, so that you'll be understanding it much better. Why we need to understand that? Because you need to understand what is the importance of interferon alpha. Why we have some new therapies that are available right now, like anti-interferon alpha therapies and all. So let us discuss the pathophysiology. So as far as the pathophysiology is concerned, the most accepted hypothesis and the most proven hypothesis is the defective apoptotic theory. In the sense, like defective clearance of apoptosis, that's called apoptotic theory, and that is the most widely accepted and the most proven hypothesis right now. So first thing to happen in SLE is something called as increased apoptosis that happens. And this increased apoptosis can be due to many environmental and existential factors. In the sense, what do you mean by environmental factors? Like virus-induced damage to the cell can increase the apoptosis in the body. For example, some existential risk factors like probably your sunlight exposure, UV rays, can result in increased apoptosis, which is a well-known fact. But normally, we also get exposed to EBV, we also get exposed to UV rays, but only by few people develop systemic lupus erythematosus, despite the fact everyone is having increased apoptosis at some point of time. This is because there should be a second problem in these patients, that is defective clearance of apoptotic cells. Defective clearance of apoptotic cells. And this is a very important point. And this is where your genetic components may come into play. Probably this is where probably your genetic influences play a role. For example, complements are the ones that are extremely important for clearing of this apoptotic cells. But because if you have a classical complement pathway deficiency, your apoptotic cell clearance may be very, very less. Probably because of that, these apoptotic cells may not be cleared properly, and you're going to have increased amount of apoptotic cells in a particular area. And that defective clearance means, like you can imagine like a dead rat. Once the dead rat is removed immediately, there won't be any problem. If you don't remove that dead rat from that place due to some reason, like you're going to have that kind of bad smell, and that will attract a lot of people to clear up that. So that's what is going to happen here. So they're going to result in the formation of something called SNECs. That's called secondary necrotic cell-derived material. That's called SNECs. So this SNEC formation will happen, secondary necrotic cell-derived material. So this is also referred to as a secondary necrosis. And this is basically very difficult really because to understand. But you have studied everywhere that apoptosis does not elicit any sort of inflammation. But here, because the apoptotic cells are basically not cleared properly, they induce a form of necrosis called a secondary necrosis. So if they induce this kind of secondary necrosis, then you will result in development of inflammation in that area. Inflammation in that area. And this inflammation is basically going to trigger off two important cells. One is going to be the plasma dendritic cell, and of course, it's going to the myeloid dendritic cell. But as far as the SLE pathophysiology is concerned, one important group of cell is there that's called a PDC, that's called a plasma dendritic cell, which is going to be the most important. Then we have another one called as MDC, that's called a myeloid dendritic cell, and that's going to be very important as well. But if they ask you the key cell in the pathogenesis of systemic lupus erythematosus, I'll be calling it as the plasma dendritic cell, which is going to be the most important in this setting. Because this is the one that has the ability to produce something called interferon alpha. And this interferon alpha is supposed to be the key molecule in the development of systemic lupus erythematosus. If they ask you the key cell, I'll tell PDC. If they ask you the key cytokine in SLE, I'll talk about it as the interferon alpha. And if you talk about the key antigen, here it is the SNECs. SNECs are the key antigen, that is secondary necrotic cell-derived material. So what's going to happen now? So this activation of plasma dendritic cells and myeloid dendritic cells, PDC is plasmacytoid dendritic cell, MDC means myeloid dendritic cell. It is given in your microbiology textbooks itself. There are two different types of dendritic cells. For example, PDC is basically like your innate immune component, innate immunity component, and myeloid dendritic cell is basically adaptive immunity component. It's a component of adaptive immunity. PDC is innate immunity component and MDC is basically an adaptive immunity component. But anyway, that discussion needs a separate kind of understanding, so don't want to confuse that. So PDC is the most important here because that's the one that produces the signature cytokine in SLE, that is interferon alpha. That's the genetic signature of systemic lupus erythematosus. So once anyway, the dendritic cells are activated, you are going to result in activation of T cells, of course. And now once the T cells are activated, you will result in the activation of B cells. So B cells will get activated because this is a T-dependent activation. And once this B cells are activated, they are going to produce antibodies. We know that. And what are these antibodies and against what they are directed against? So here I told you the key antigen that we are dealing with is the SNECs, that is secondary necrotic cell-derived material. As the name suggests, it's a cell-derived material, which means from where they are derived, they are actually derived from these apoptotic cells. From where these apoptotic cells are coming, they are coming from normal cells in the body. So which means these antibodies will be directed against the normal cells and their components. So this explains the development of different form of anti-nuclear antibodies like anti-dsDNA against the double-stranded DNA, ribosomal components against the cytoplasmic components. So you result in the development of a lot of antibodies. All these antibodies will come under a common terminology called as anti-nuclear antibodies. So once these antibodies are formed, these antibodies are going to have multiple effects, and one of the important effects is they're going to cause cell damage, and they're going to cause further complement activation. Few antibodies, not all. See, ANA is like a spectrum of antibodies. It's not like ANA means one antibody. ANA is a spectrum of antibodies. So many antibodies will come under anti-nuclear antibody spectrum. So few antibodies can activate complement, so they can cause complement activation and resultant immune complex deposition, and which can result in more and more damage to the cells and the body tissues. And this more cell damage means you're going to basically result in, maybe I can put a line. This more cell damage technically is going to result in more apoptosis, by the way. So in a sense, this cycle will keep on continuing. So they will produce more SNECs because already they have defective clearance. More SNECs means more PDC activation. More PDC means more interferon alpha, and more T and B cell activation, and more antibodies, more damage, more immune complexes, and this cycle will keep on continuing. And one of the key features in SLE is the fact that these B cells have long-term survival, and many studies have shown that these B cells are very important in SLE, and they typically have a long-term survival. And later on, when they started examining how these B cells are surviving for such a long time in systemic lupus erythematosus, they found out there are two key molecules that are important. This happens in any condition, but in SLE, they found out that these are present in excess and they sustain the B cell number and proliferation. So these are substances like Bliss and April. Of course, in that, the Bliss is going to be the most important. That is the B lymphocyte stimulator. That's called Bliss. And we have another molecule called April is also there. This Bliss is also referred to as something called a BAF. Other name for Bliss is also called as BAF. That's called a B cell activating factor. This Bliss or BAF is going to act on BAF receptor. That's called a BAFR on the B cells, and they sustain their survival. So that's the idea. And to be honest, this Bliss can be the Bliss production can be activated. This because this Bliss is basically coming from the stromal cells. Stromal cells in the bone marrow. In the bone marrow, you have some supporting cells. We know that stromal cells in the bone marrow. And this interferon alpha can stimulate the stromal cells in the bone marrow to produce more and more Bliss. So that's where interferon alpha is very important. And remember, this interferon alpha has one more action by stimulating the myeloid dendritic cells to activate more and more T cells in this setting. So this interferon alpha has a potentiating role, which means they're going to potentiate the B cell survival and they're going to potentiate the myeloid dendritic cell action to produce more and more, to stimulate more and more T cells. That's why I told you the myeloid dendritic cells are basically components of adaptive immunity. So that is how they can activate the T cell. So this interferon alpha has an additional role in boosting effect. They're going to stimulate the myeloid dendritic cell to produce more and more T cells in this regard. So interferon alpha also can do one more thing. Like for example, they can also activate the production of something called NETs. These are called as neutrophilic extracellular traps. Everyone will know that because you have studied pathology. So we know what you mean by NETs. Neutrophils has 3 different kinds of killing. So the first important kind of killing is phagocytosis. Second way of killing is degranulation of the toxic substances on the bacterium. And third common form of killing is the NETs. So this not have been suggested before 1 decade, but in the last 1 decade, we know the third form of killing mechanism of neutrophils is this formation of neutrophilic extracellular traps. So this interferon alpha is known to increase the production of NETs. So which means what are NETs? Basically, these NETs are like these are neutrophilic cytoplasmic and nuclear components. So they take the chromatin out and they mix with the cytoplasmic granular components, and they're going to then release that in the form of a web, so that they form like a sort of a trap, like a spider web. Any pathogen that is passing through that area will be trapped in that web. So either they will be killed by the substances that are present within the web, or if it's not killed, if it gets trapped in that web, then another neutrophil will come and swallow it and it will kill. So that's why the NETs are formed. It can be formed by a healthy neutrophil as well as a dying neutrophil, but once NETs are formed, nevertheless the neutrophil has to die. So that's the idea. Even though that view is changing right now, but these are the basic views about the NETs in the first place. So what is the problem in the NETs? Because this NETs has to be cleared once again by cytokines. So NETs has to be cleared, not cytokines, the NETs has to be cleared by complement proteins. If the NETs are not cleared by complements, poor clearance, because these patients are known to have some genetic problem that results in the poor clearance of not only apoptotic bodies, even the poor clearance of NETs. So you know what these NETs are basically? These NETs are nothing but the neutrophilic components, that is the cytoplasmic and nuclear components, which can still result in the development of the antibodies, because that will not be cleared if the complements are not working properly. In that setting, they can also result in the development of antibodies. In this setting, the best example is Hunker-related antibodies. Even SLE patients can have anti-neutrophilic cytoplasmic antibodies, and that can be explained by the poor clearance of neutrophilic extracellular traps. So you can see that interferon alpha plays a very important, central role in the pathogenesis of systemic lupus erythematosus. The plasmacytic dendritic cells also play a very important role, and these antibodies play a very important role as well. And finally, the last stage is the complement activation and cell damage and immune complex formation. All these things play a very, very important role. So the widely accepted hypothesis as of now is the defective clearance of apoptotic cells. This is the theory that is currently accepted in a very large way. So this is a pathogenesis of SLE in a nutshell. And this understanding of pathogenesis have helped us in a big way, in the sense like we started developing targeted therapies. If you ask 1.5 decades back, SLE target therapy, people would have laughed because there is no target therapy, because SLE pathogenesis were very unclear. So that's why we were using cyclophosphamide, we are using calcineurin inhibitors to some patients, and we have been using steroids. These are highly non-targeted therapies. You don't target against any molecule when you use a cyclophosphamide or a steroid drug, glucocorticoid drug. But later on, we started developing target therapies because now we understood the pathogens of SLE in a much better way. So there are some examples of target therapies where you can tell. For example, you can block the interferon alpha now, knowing that that interferon alpha is one of the key pathophysiological feature in the setting of SLE. And you can block this BLyS, knowing that this BLyS is also one of the important molecules that play a very important role in the survival of the B cells that produces antibodies, or you can actually block the production of antibodies by targeting these B cells as well. So for example, one of the best examples, there are many drugs are there, but the best example of an interferon alpha inhibitor is something called as runtalizumab is there now. And we have another drug called cifalimumab. Cifalimumab is something that is already there in India right now. So that could be a probable question. And another drug which has been used for a very long time, in fact, like the last 7-8 years, we've been using with a good outcome in certain mild to moderate patients is belimumab. Belimumab is a BLyS inhibitor, which is a monoclonal antibody against BLyS, which is useful for mild to moderate SLE. And we can, of course, we can damage the B cells also, like CD20 inhibitors are there. So for example, rituximab. So we can reduce the production of antibodies. Rituximab is used in some specialized scenarios, which I'll be telling you in some time. So currently we are moving from a lot of non-target therapy to a lot of target therapy as far as our SLE is concerned. So they might be asking one of these drugs in exam. So be a little clear about what happens in the pathogenesis and why we are using these drugs. You have to be very clear. So again, key antigens, next key cytokine, interferon alpha, key cell that is important SLE is plasmacytoid dendritic cell, PDC, and key molecule that maintains the B cell survival is going to be the BLyS, that is B cell activating factor. So this is the entire pathophysiology of SLE in a small nutshell, but still we have a long way to go. We don't really understand the disease completely, but we had a terrific understanding in the last 1 decade compared to what we had in the previous decades. So this must be enough, and we need to know about the clinical features of SLE. That's the most important, because this is something that will help you identify these patients at risk and treat them early, because if you treat early, they might have a better outcome compared to the time when you treat the organs are already damaged. As far as the clinical features are concerned, the number one, the most common is going to be the constitutional symptoms. That's going to be the most common. Overall, if you ask me, among the constitutional symptoms, most common is going to be the fatigue. Fatigue is a very, very common symptom in SLE. Almost more than 95% of the SLE patients will have some form of fatigue. Apart from that, they can have minimal weight loss, they can have weakness, they can have this malaise, anorexia. Yes, all these things can happen. And when you talk about the systemic manifestation, the word SLE tells systemic lupus erythematosus. So you need to have some systemic manifestations. They ask you the systemic manifestation, the musculoskeletal involvement is going to be the most common systemic involvement. So which means I can write that the most common systemic manifestation of SLE, even though the most common is constitutional symptoms only, but the most common systemic manifestation in SLE is going to be musculoskeletal involvement, MSK. In the musculoskeletal involvement, the most common is going to be arthritis. So many SLE patients will be suffering from arthritis. You would have studied, isn't it? That's an old ACR criteria. Based on that also you can remember there is something called as MD Sobrin or Sobrin MD, whatever may be the fact. This is an old ACR criteria that was given in 1997. During that time, this mnemonic was extremely famous in many MLE exams. Right now, with the advent of modern slick criteria and all, this is not used that much. But nevertheless, M stands for malar rash and D stands for discoid rash and S stands for serositis and O stands for oral ulcers and A stands for arthritis and P stands for photosensitivity and B stands for blood manifestations. R stands for renal involvement, that's called lupus nephritis. A stands for ANA positivity and I stands for immunological features in SLE and N stands for neurological involvement in SLE. So this is the old ACR criteria, 1997 criteria, which is given by a mnemonic called SoBrainMD. They told like if you have 4 out of 11, then you can call it as systemic lupus erythematosus. And ANA should be positive. That they made it mandatory later on because of some pitfalls in the criteria. But nevertheless, we don't use this criteria right now. Instead, there is another criteria that came in 2011 and it was revised in 2015. 2011 SLIC criteria came, and after that in 2015 they made it revised SLIC criteria. That's what we follow now. But nevertheless, I told you I'm not a big fan of criteria because these criteria will not make you a good clinician, and at the same time you might be tending to miss a lot of diseases if you are a criteria freak. And that's the reason why any criteria, if you take, go and check back in any textbook or any criteria, they are clearly given. This criteria should be used only in research purposes. You should not use this criteria in your day-to-day clinical practice. The clinical experience is more important than sticking in this criteria and all. So suppose if you're doing some clinical research in the setting, like if you're doing some research on SLE, for example, you want to assess some drug, whether it works or not. In that condition, if you want to know that this patient is really having an SLE or not, that time to have some criteria standard to tell that this patient is suffering from SLE, you can use a criteria. That's what they're trying to tell. So research purposes means when you're trying to do some research, in that you want to define that this group of patients are having SLE and this group of patients are not having SLE. For that, you can use this criteria. But for day-to-day clinical practice, these criteria are not that sensitive or not that specific to define a particular disease. So be very careful in that setting. So as I told you, arthritis is going to be extremely important in the setting of systemic lupus erythematosus. And typically this arthritis is supposed to be non-erosive, and that's what you have to answer in exams. Whenever they ask SLE related arthritis, it's always supposed to be non-erosive forms of arthritis. Remember, there are 2 to 3 arthritis in exam where you should know it is non-erosive. One is of course systemic lupus erythematosus. Second is of course acute rheumatic fever. Very common example of non-erosive forms of arthritis. Majority of the viral arthritis that you encounter are non-erosive forms of arthritis only. And fourth, if you want to know, the relapsing polychondritis that we saw there is also one of the important evidences of non-erosive arthritis. In fact, the rheumatoid factor and ACPA, these are 2 antibodies that are basically associated with something called erosions. Any patient who don't have rheumatoid factor or any patients who don't have ACPA can develop, usually do not develop erosions. So RF positivity, ACPA positivity is very important to develop erosions in the first place. So basically this is supposed to be a non-erosive arthritis, number 1. And Pranavi is asking, can deformities seen in non-erosive arthritis? Of course, yes. I told you already. How many times you need me to tell? I told you already, isn't it? So that deformities are due to tenosynovitis and not due to erosions and not due to whether arthritis are there or not. So I told you the same form of deformities that you see in rheumatoid arthritis can be seen in SLE also. I think I told you that point specifically yesterday. So why the same question again? Can deformity seen in non-erosive arthritis? It can be seen, of course, yes. So nothing prevents you from developing deformities if you don't have erosions, because that is due to tenosynovitis and resultant subluxation of the joints. So first of all, it's a non-erosive arthritis. That's what you have to tell in exams. But despite the fact, that's the next point I'm going to tell, despite the fact that it is non-erosive arthritis, you can get deformities, of course, because deformities are basically due to tenosynovitis and not really due to arthritis. For that matter, you should ask that question. In rheumatoid arthritis, if DAP joint is not involved in arthritis, then why should you get swan neck deformity, where there is a flexion at the DAP joint and hyperextension at the PAP joint? This is swan neck, isn't it? So why you should get this hyperflexion at the DAP joint if DAP joint is not involved in rheumatoid arthritis? That's because it's not due to arthritis. That is due to tenosynovitis that is happening elsewhere that causes subluxation of the joints and some different mechanics that's happening in the finger and the hand. So deformities, you can get the same deformity, like whatever deformities that I have seen in RA, the same deformities can be seen here, like swan neck deformity, Boutonnet deformity, Z deformity of the thumb, or otherwise referred to as hitchhiker's thumb. All these deformities can be seen. In fact, here also the most common deformity, if someone asks you, it's again the ulnar deviation of the hand. That's going to be the most, ulnar deviation of the fingers. That's going to be the most common deformity even in patients with systemic lupus erythematosus. Fine. So if the patient has deformities, then you might be asking what is the name given to that. That's typically referred to as Jacot's arthritis. once the patient develops deformities in SLE, that will be called by a different name called Jacquard's arthritis. So now there has been a natural question: how will you differentiate a Jacquard's arthritis from a rheumatoid arthritis? The first thing, as far as Jacquard's arthritis is concerned, there will be no erosions because it's non-erosive. As far as rheumatoid arthritis is concerned, they will have erosions, of course. So it's an erosive arthritis. That's one basic difference. At the same time, Jacquard's arthritis is classically painless. These are painless deformities, whereas rheumatoid arthritis deformities will be a little, sometimes even they can be excruciatingly painful. They are painful form of deformities. But most important thing comes here. Here the patients will be having ANA positivity and RF and ACPA negative. Here the patients will be RF and ACPA positive, but they will be ANA negative. So very easy difference. So that's why I told you, whenever the patient is RF and ACPA negative, don't conclude that it's a seronegative rheumatoid arthritis. Instead, you can make it a seronegative arthritis, but don't even comment that unless and until you do other markers like ANA and your other serological markers. Till that, don't conclude it's a seronegative arthritis. There could be something else in the patient. And I told you, as I told you, this RF is very important for developing erosions. So that is the reason why very few SLE patients, not all SLE patients, very few SLE patients can develop erosions, but this should not be told in exam. In exam, whenever the question is asked, you should tell it is non-erosive arthritis only. Very rarely, but for a knowledge, I'm telling, patient with SLE can develop erosions. If they do develop erosive kind of arthritis, suppose if they develop erosive kind of arthritis, very few patients, very rarely. So this kind of arthritis is what we refer to as something called as a rupus. That is called as a rupus, which means it's a combination of a rheumatoid arthritis along with the lupus. So that's why it's called as a rupus. Usually these patients will be having ANA positivity as well as RF positivity, but in fact RS will be in very high titers in these patients. That's kind of a mixed bag scenario where you can get this rupus and you can get erosions, but that's only for your knowledge. I'm telling again and again, anytime in exams, if they ask, this is what you have to answer. That is, SLE arthritis is typically non-erosive forms of arthritis. So the first one is over, the musculoskeletal involvement, that is arthritis. And next, they can have mucocutaneous involvement. One of the very common things in systemic lupus erythematosus is in the mucocutaneous involvement, the first thing is going to be the alopecia. Alopecia is one of the very common entities in SLE, happening in almost 70-80% of SLE patients develop some form of alopecia. And usually this alopecia will be of non-scarring type, which means that does not scar. And the usual reason for development of alopecia in SLE patient is telogen effluvium. That's due to stress causing increased hair loss. It can happen in many other conditions. SLE also can cause telogen effluvium, and they can cause this kind of non-scarring type of alopecia. They can develop scarring type of alopecia in case if the patient develops this kind of discoid lupus lesions or chronic cutaneous lupus erythematosus, which we'll be discussing subsequently. But alopecia is again usually due to telogen effluvium, which should be non-scarring. And next, you can get oral ulcers. One of the important features of these oral ulcers is the fact that they are painless, not like aphthous ulcers, which will be excruciatingly painful. And more importantly, these ulcers will have an erythematous base, whereas your aphthous ulcers will be having more of a necrotic base rather than erythematous base. And of course, these ulcers, most common location is going to be in the palate rather than the tongue or in the oral cavity. Other areas of the oral cavity, it will be in the palate usually, and they will have more erythematous base, and they will be typically painless in this setting. Okay. After these oral ulcers, it's important to know another mucocutaneous involvement. In fact, the skin involvement per se is very common. Skin involvement is a little tricky to understand. Why it is a little tricky to understand? Because this is called by a separate disease called cutaneous lupus erythematosus, CLE. And CLE patients may have association with SLE, that is systemic lupus erythematosus, or SLE patients, or CLE can come alone without having any other underlying systemic manifestation. So it's like a tricky scenario where CLE can come alone, which means the skin lesions that are typical of lupus can come as a separate entity without any systemic manifestations, or they can come along with underlying systemic manifestation to call it as SLE. If a patient who's having cutaneous lesions similar to that of lupus is getting only skin lesions, but there is no any evidence of underlying SLE, it will be still called as a cutaneous lupus erythematosus only. A patient who's having SLE and develops skin lesions will be still calling it as SLE, but having some cutaneous manifestations. That's how you have to call, and it's a little tricky. Nevertheless, you need to know that CLE can manifest alone without any underlying systemic manifestations to call it as a systemic lupus erythematosus. Remember the fact that all skin lesions that you get in CLE or SLE, doesn't matter, are going to be photosensitive, which means they're going to get flared up when they are getting exposed to sunlight or UV radiation. All are photosensitive. And we have something called a Gilliam classification. So this Gilliam classification tells that you can split the SLE into 3 types. One is called as acute cutaneous lupus erythematosus, called as ACLE. Second is called as subacute cutaneous lupus erythematosus, called as SCLE. And third is called as a chronic cutaneous lupus erythematosus, called as CCLE. You can have ACLE, you can have SCLE, then you can have something called a CCLE, chronic cutaneous lupus erythematosus. Each and everything has some typical manifestations. For example, as far as acute cutaneous lupus erythematosus is concerned, that is ACLE, you have some 2 characteristic types in that. The first type is called as a localized ACLE, and the second one is called a generalized ACLE. So how will you differentiate whether it's a localized or generalized ACLE? Whenever the patient is having lesions below the neck, so that will be called as a generalized ACLE. Whenever the patient's lesions are limited to the face and not crossing the neck area, then it will be called as a localized ACLE, localized acute cutaneous lupus erythematosus. And there is a third type of ACLE called as TEN type of lesion. That's called toxic epidermal necrolysis type of lesions, or TEN-like type of lesion. That's the third form of ACLE is also there, which is not important for your exams. As far as your exams are concerned, the most important is going to be this localized form of ACLE. So most important localized form of ACLE is the typical malar rash that you get, very common in SLE patients. Remember, the typical description of malar rash that is given in Western textbooks may not fit Indian patients, because Indian patients differ in the way and type and distribution of malar rash. But nevertheless, you need to know about the classical features of malar rash. Number 1, malar rash is going to be of butterfly shape. Why it is butterfly shaped? Because it is symmetrical. It is symmetrical on either sides because it is symmetrical. But even though Indian patients may be having asymmetrical lesions also, but typically the Western description is the fact that they will be symmetrical. Because it's symmetrical, they will produce this kind of a butterfly type of a rash. Clear? So apart from that, they will be more erythematous than pigmented. They won't be pigmented and they'll be more erythematous, which means there will be no hyperpigmentation in that area. That's a very important point. Even though small amount of hyperpigmentation can happen in Indian patients, but nevertheless, no hyperpigmentation. Classic description. They'll be having only erythema and they'll be crossing at each other. They go to the other side and they will be connected together at the nasal bridge. Nasal bridge is the the area where both the side lesions will be having connection with each other. Clear? So we know that. At the same time, one more important point is the fact that they will not involve nasolabial folds, which means I can, rather than writing not involving nasolabial folds, I can write sparing of the nasolabial folds. They sparse the nasolabial folds because you have another disease called acne rosacea, which is one of the important dermatological differential diagnoses, which typically tends to involve the nasolabial folds. So here it will not involve the nasolabial folds anyways. And they finally, you can say that they heal without any scarring. So once the disease is gone, they heal without any scarring. So if they ask you the closest TD for this malar rash is going to be acne rosacea only in dermatology, and that will involve the nasolabial fold. That's all. As far as your ACLE is concerned, if somebody asks you which of the following lesions among the 3 lesions which are talking about, ACLE, SCLE, and CCLE, which has the maximum association with the underlying systemic lupus erythematosus, answer will be ACLE. ACLE has more than 90% association with systemic lupus.
That's why you're on a call.
See, I think Siri got activated again. Okay. More than 90% of the ACLE lesions are basically associated with systemic lupus erythematosus, which means there can be an underlying SLE in this setting. So if they ask you the most common lesion, the maximum association with underlying SLE, answer will be ACLE lesions. That is acute cutaneous lupus erythematosus. That's all. Fine. All right. Then what about the SLE? That is subacute cutaneous lupus erythematosus. As far as SLE is concerned, it has 50% association. So not like ACLE, 50% association with SLE is there, which means whenever you see a patient with subacute cutaneous lupus erythematosus, there could be a possibility that 50% of these patients may have a underlying systemic lupus erythematosus. Typically, the lesions are described as having annular, and there will be papillosquamous and soriaform. Soriaform means they might have some amount of plaques, some amount of scaling will be there. So that's what we called as a soriaform, which means which fuse together to form some hexagonal shapes. For example, I can write something like this, and there will be surrounding erythema. For example, I can see this kind of erythematous lesions like this that like join together to form these kind of structures. That's characteristic. So this is how they come, and they can be seen anywhere, but very commonly they will be seen in the trunk and the extremities. So which I'll show you. I mean, in the form of neonatal lupus, I'll show you that lesion, how they will look like. So most common area they will involve is the trunk, and plus or minus they can involve the extremities also. But most importantly, they will be coming in the sun-exposed areas only. Of course, sun-exposed areas, they'll be with relatively more severity. That's all. So again, they heal without scarring. They don't really scar. They heal without scarring, but they can have some residual hypopigmentation. After healing, they may leave some residual hypopigmentation, but they generally heal without any scarring. Clear? Sometimes you can have this kind of a target lesion kind of an appearance rather than like having this kind of erythematous kind of lesions. Sometimes, rarely, they can have this kind of target kind of lesions. So when you actually call it as a target lesion, so when you have this kind of target kind of appearance, I think this is not correct way to draw. So this is what we call as a target lesion. When you have a surrounding erythema with a central clearing or a central, erythema, this is what we call as a target kind of lesion. This, whenever you have a target lesion in the body, that will be called as erythema multiforme-like lesion. I think you would have studied all this in dermatology itself. Erythema multiforme is a less severe variant of your more severe disorders like SJS and 10. So, your Stevens-Johnson syndrome and toxic epidermal necrosis. So erythema multiforme-like of lesions, these are basically target appearance. So this kind of erythema multiforme-like lesions that happens in SCLE, that is subacute cutaneous lupus erythematosus, is also referred to as something called a Rowell syndrome. So if they ask you what do you mean by Rowell syndrome, these are nothing but SCLE lesions, subacute cutaneous lupus erythematosus lesions, which are typically going to look like target lesions. That is erythema multiforme-like lesions called as Rowell syndrome. That's also part of SCLE only, subacute cutaneous lupus erythematosus. Then as far as CCLE is concerned, you have a variety of lesions in chronic cutaneous lupus erythematosus. For example, the most classically described lesions and the very commonly asked question in exam is the DLE, that is discoid lupus erythematosus. And apart from that, they have something called lupus paniculitis, and they can have something called a lupus profundus. They can have something called lupus timidus, and they can have something called a chilblain lupus. Chilblain lupus. So we have different types of chronic cutaneous lupus erythematosus. Of course, in exam, the most classic question is going to be on the discoid lupus erythematosus. They ask you what is the percentage of association with systemic lupus erythematosus. It's variable around 5 to 30% association with underlying SLE, which means they can have underlying systemic lupus erythematosus in 30% of the cases. The risk is more if ANA is positive. If ANA is negative, the risk is less. If ANA is positive, the risk is going to be very high. So now we have to describe this DLE lesion. DLE is a very important question in exam. Discoid lupus erythematosus lesions, one of the classic forms of chronic goodness lupus erythematosus. DLE lesions can again be divided into two. One is going to be the localized DLE, that is going to happen only in the face and the scalp above the neck, or you can have a generalized DLE where they have lesions below the neck also. That's what we call as generalized DLE. But nevertheless, whatever may be the type of DLE, the most common site is going to be the face, which will be then followed by the scalp. So if at all, if it's going to occur in the scalp, they can produce scarring type of alopecia. We told like SLE typically produces non-scarring type of alopecia only, but if it's associated with discoid lupus erythematosus, they can produce this non-scarring type of alopecia. So how the DLE lesions typically look like? So they look like, as if they have this oval kind of an appearance or a flat kind of an appearance, where there'll be a surrounding erythema. And you'll have some sort of a central pale and an atrophic scar. So centrally you can talk about a pale. There's an atrophied area, atrophic scar, and which will be surrounded by an active edge. There's an active edge, that's a surrounding erythema that these patients have. And they're going to expand centrifugally like this, which means from inside to outside, if they expand, that centrifugal expansion. From outside to inside means it's centripetal compression. So it's a centrifugal expansion that they're going to get from the outside. This area is going to keep on increasing. And more importantly, on the top of that, they'll be covered with scales. So that a scar area and the erythematous area may be covered with a scaling. They can have scalings. So scales are very prominent in the setting of a DLE. Remember, usually ACL lesions will not have any scales at all. ACL lesions may have some amount of scales, but we're not typically like too much scales. CCL lesions, especially DLE, is going to produce a lot of scaling. That's very characteristic of chronic cutaneous lupus erythematosus. And the most important fact is that these lesions are at a higher risk of developing future squamous cell carcinoma. Any CCL lesion for that matters, but more importantly, this DLE lesion has a higher risk of developing future local squamous cell carcinoma. And whenever you take a biopsy from this lesion, they can show some characteristic findings. I used to write as KFC findings. So KFC, K stands for keratotic scaling, and F stands for follicular plugging, and C stands for cutaneous, that is dermal atrophy, cutaneous atrophy. So keratotic scaling, follicular plugging, and cutaneous atrophy, KFC findings. That's what you see in the setting of a biopsy when you take from the edge of the lesion. And the biopsy is advantageous because it can rule out squamous cell cancer as well. And apart from that, there is one important sign is there that is associated with this discoid lupus erythematosus lesion, that if you take this scale and you can take a knife and you can, scales are not painful, so you can remove that scale. So you can, with a knife, you can remove the scale, and you take a scale and you turn upside down. You turn upside down, and if you see the area of attachment of the scale with the skin, you will be seeing a lot of dot-like structures. Will be there. These are nothing but the follicular plugs. These are the follicles that you're seeing that are attached to the skin, and this sign is also referred to as something called a carpet tack sign. Everyone would have seen the carpet tack, isn't it? So, where they use this kind of tacks in marriages and all. When they use a big carpet, they used to not stitching, it just fix the carpet. They use this tacks, small kind of this kind of nail-like thing will be there. So they used on the sides, the center, they used to tack it. So this is what we refer to as a carpet tack sign, because it looks as if a carpet is getting tacked in that particular area, attached to that particular area. So anyways, nevertheless, the most important point is they can scar. That's very, very important. Previous two lesions, we told that they don't that they heal without scarring, but these lesions are going to basically scar. Among all the lesions, if they tell you the most, like photosensitive lesion, among all, if they tell you the most photosensitive lesion, from ACLE to SALE to CCLE, what is going to be the most photosensitive lesion of all? Any idea? I mean, I told so many lesions, but which lesion is the most photosensitive? The most photosensitive. All lesions are photosensitive, but the most photosensitive. Yes, that is lupus timidus. Pranavi told it right. So the lupus timidus is the one that tends to be the most photosensitive lesion of all. Highly photosensitive. And one more important thing is this DLE. If you do something called as a lupus band test, that's an immunofluorescence test. That's called a lupus band test, and that will be positive in a DLE lesion. Any CCL lesion can show positivity, but it's prominently positive in a DLE lesion. That's called a lupus band test. It is actually done through immunofluorescence technique, where you can see deposition of the immune complexes in the surface of the skin, and that is clearly visible in a DLE patient. That is called as lupus band test, which is going to be positive in this situation. And I think the skin lesions are over. Then apart from that, you have vascular involvement in SLE. Vessel involvement can be there. So I think megacutaneous done. So fourth manifestation is the vascular involvement. Vascular involvement is we are talking about number one is the Raynaud's phenomenon can happen in SLE. This is basically a secondary Raynaud. Primary Raynaud is basically idiopathic, and they can have thromboembolic features. Thromboembolism is very common. And this is extremely common if the patient has underlying APLA antibodies. So increased risk if the patient is having APLA antibodies. We'll talk about what are APLA antibodies in some time. If the patient has APLA antibodies, then it is going to have a higher risk, thromboembolic manifestations. Then they can have accelerated atherosclerosis. And please understand, as I told you in the yesterday's lecture itself, the most common cause of death in patients with SLE is going to be cardiovascular death only, MI, myocardial infarction, because their vasculature will be so bad. So accelerated atherosclerosis is extremely common in the setting of systemic lupus erythematosus. At the same time, they can produce vasculitis also. They don't produce large vessel vasculitis like picture, but they can produce a sort of a medium and a small vessel vasculitis also. But very commonly, they'll involve the small vessels than the medium vessels. They can produce vasculitis as well. I will be discussing about that. So what do you mean by small vessel and medium vessel vasculitis? Remember, they can generate ANCA as well. SLE patients can generate anti-neutrophil cytoplasmic antibodies. Remember, SLE is like a hub of antibodies. You can develop any antibodies in SLE. That's why I told you in the pathogens itself, this net formation is one thing that increases the risk of development of anti-neutrophil cytoplasmic antibodies, ANCA. So you can develop ANCA also. So after the vascular involvement, we're going to talk about the individual organ involvement. The first one is going to be the cardiac involvement in SLE. So most common manifestation of cardiac involvement is pericarditis, like rheumatoid arthritis. They can also cause pericarditis, but usually they will be asymptomatic. They don't really result in tamponade or pericardial effusion. And at the same time, they can have valvular heart disease also. Valvular heart disease. Remember, the most common manifestation of valvular heart disease, asymptomatic thickening of the valves. Just there will be thickening of the valves, and this it will involve the mitral valve followed by the aortic valve. So the most common valves that are affected in this valve thickening is the mitral valve, then the aortic valve. And one more important point to note, that is this thickening of the valves, risk is increased with presence of APLA antibodies. If you have APLA antibodies, this anti-cardiolipin antibodies, you have anti-beta-2-glycoprotein 1 antibody, or you have lupus anticoagulant, so they can increase the risk of development of valvular thickening. And if they ask you most common valvular heart disease in patients with SLE, of course, answer will be mitral regurgitation. So that is going to be the most common valvular heart disease. But the most common manifestation is just asymptomatic thickening of the valves. But most common valvular heart disease that you will get in the patients with systemic lupus erythematosus is mitral regurgitation. Then third, apart from that, they can get endocarditis. And this endocarditis will be sterile. And you know what is the reason for development of this endocarditis? I mean, what is the name given for this development of endocarditis? That is Liebman-Sachs endocarditis, LSE. Liebman-Sachs endocarditis. And of course, you need to differentiate between the three things. One is the infective endocarditis. Second is the NBT, that is non-bacterial thrombotic endocarditis, which can happen in setting of a lot of mucin-producing adenocarcinomas. And third one is the Liebman-Sachs endocarditis, that is LSC. As far as pathophysiology is concerned, infective endocarditis is infectious in nature, which means it is infective. NBT and Liebman-Sachs endocarditis are basically non-infective in nature. They're not infective. And you know what is the reason for that? So this is basically due to mucin-producing adenocarcinomas. Mucin that is coming from adenocarcinoma can be usually from the GI tract. Here the usual reason is the antigen-antibody complexes that is getting deposited, especially in the setting of APLA antibodies. Most important is APLA here. So result of that, there will be localized fibrinous necrosis of the valves. That's the reason for development of this Liebman-Sachs endocarditis. So what is the status of the valve? Remember, as far as infective endocarditis is concerned, most probably the valve will be an unhealthy valve, which means it will be a damaged valve. Damaged valve more than the normal valve. Getting an infective endocarditis a normal valve is very rare. Usually it will be happening in the setting of a damaged valve, like already there will be MR, already there will be AR, something like that. So in NBT, you can get in a normal valve. In LSC, you can also get in a healthier normal valve. As far as the site is concerned, it's variable, but typically if you take a valve like this, typically speaking, the vegetations will be small and they'll be located on the tip of the valve. So this location at the tip of the valve, and this small vegetations initially will be there that coalesce to form a big friable mass. Big friable mass. So that's very characteristic of infective endocarditis. Initially, they'll form a small vegetations. Later on, they coalesce with each other. They combine together, form a big friable mass. The word friable is very important because they have an extremely high risk of thromboembolism to different areas. They can produce a shower of septic emboli in multiple different areas, including CNS, lung, and everywhere, depending on the area of presentation. Usually located on the tip of the valve. That's a very classic location for your infective endocarditis vegetation. That's why, because they are in the tip of the valve, so when the tip of the valve comes and closes, because the destruction on the tip of the valve, there will be a prolapse. So that is the reason why infective endocarditis commonly presents with insufficiency, new regurgitant lesions rather than stenotic lesions. And at the same time, they will be usually present on low pressure sites. Site will be low pressure areas. Low pressure area in the sense whichever between two chambers, if you get infective endocarditis, whichever chamber has low pressure, in that chamber only there is a high chance of getting an infective endocarditis vegetation. In the sense, like if you have a mitral regurgitation, so you know the high pressure chamber is the ventricle and the low pressure chamber is the atrium. So very commonly they're likely to present on the atrial side. So that's where the infective endocarditis vegetations will be located, in the low pressure chamber, whichever the chamber that is having a low pressure relatively. And as far as the NBT is concerned, they generally tend to be small vegetations, and as well as the Liebman-Sachs endocarditis is concerned, they generally tend to be medium-sized vegetation. It's somewhere between small as well as medium. On the other hand, if you see where you're going to get the NBT vegetations, once again you will get in the low pressure zones, which means you will be getting this vegetation in the atrial side very commonly. But very commonly they will be located on the line of closure. That's very characteristic. They'll be located along the lines of closure of the valve, not in the tip of the valve. And around the annulus, along the lines of closure, they'll be located very typically in the low pressure zones and near the atrium, of course. And finally, you have this kind of Liebman-Sachs endocarditis. Again, the characteristic feature of this is they can be located on atrial side as well as ventricular side. There is no preference, like they'll be located on atrial and ventricular, atrial or ventricular only. They'll be present both atrial and ventricular side, which means there's no location preference here. So they can be located here, 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 even on the other side of the valve, which means they can be present on either side of the valve. Either side of the valves. So they can be randomly located. And as far as the risk of thromboembolism is concerned, so they have a lesser risk. This NBT and LSC has a lesser risk of developing thromboembolism, whereas infective endocarditis is the one that has the highest risk of having thromboembolism. Remember, it is not like LSE and NBT can't produce a thrombus. They can still do produce a thrombus, but the risk is comparatively lesser compared to that of your infected endocarditis vegetations. So that's all. So SLE can rarely produce myocarditis. Myocarditis is the next manifestation after endocarditis, but rare. It's not very common. Rarely can produce myocarditis. Then I think the sixth manifestation we're going to talk about is a pulmonary manifestation of the lung manifestation in SLE. As far as lung manifestation SLE is concerned, again, the most common will be the serositis, that is pleuritis, very common. Even in the old ACR criteria, in the MD Sobrain, the S stands for serositis. Serositis is such a common entity in SLE. So pleuritis can result in the development of pleural effusion, and this pleural effusion generally tends to be exudative in nature. We know they're going to satisfy the Light's criteria of exudative pleural effusion. And if you see the difference between rheumatoid arthritis and SLE, rheumatoid arthritis tend to be generally producing a large effusion, and significant reduction in the glucose will be there. And whereas SLE tends to produce smaller effusions, and usually they'll have a normal or only mild reduction in the glucose content. As far as SLE effusion is concerned, I think yesterday itself we saw this, and both will produce low complements in the effusion. So that's not a difference. Hypocomplementemic effusion, that is because the complement consumption in both these disorders, because both these are antibody related problems, and both can activate complements, and both can produce complement consumption, low complement subsequently. And then we can get another entity called as pneumonitis in SLE, not very common, and they can also develop something called ILD, that is interstitial lung disease. Remember, ILD is very rare, less than 5%. That too happens in extremely late stages. If the disease presents with early lung disease, that is unlikely to be SLE. It cannot be SLE usually. So ILD is extremely rare in SLE. But one more thing that is commonly described in SLE patients is something called as SLS, that's called as shrinking lung syndrome, that can be seen in the patients with SLE. Usually this shrinking lung syndrome is associated with an antibody called anti-Rho antibody. So the best example is, like, I'll show you an image so that you will be understanding better about the shrinking lung syndrome. This is an example of a shrinking lung syndrome. So this is a patient who was diagnosed with SLE, maybe, I don't know the exact date, I think it must be 2014, same patient. Same patient admitted again with ICU, again in ICU in 2018 around. So you can see the difference. So the lung size has substantially shrinked, and it has markedly reduced. And I mean, one important probable reason is that, I mean, many people think like it's parenchymal lung disease, but it's not parenchymal lung disease. It is due to the fact that there will be severe myositis in SLE. And anti-Rho antibodies are strongly related to myositis, and this will affect the diaphragm. There will be diaphragmatic myositis causing diaphragmatic weakness and damage. And there will be intercostal myositis as well. Because of intercostal myositis and diaphragmatic myositis, there will be weakness of these muscles, resulting in, elastic recoil of the thorax, causing a little bit of, like lung volume itself will shrink if these muscles are not, having a good strength. So in that setting, it will look like as if the lung itself has shrunken to a very small size. This is what we refer to as something called a shrinking lung syndrome. So this is an example of a lupus band test. I didn't tell you, I told you before. In certain patients with SLE, especially if they have discoid lupus erythematosus, if you subject them to immunofluorescence, you will see this kind of band-like appearance in the dermal area. So this is what we refer to as a lupus band test. But nevertheless, shrinking lung syndrome is due to myositis, and you have to understand that it is not due to your actual parenchymal lung disease. Clear? It is due to myositis of the diaphragm and the intercostal muscles, causing weakness and causing shrinking appearance of the lung, as with anti-Rho antibodies. Then we have neurological involvement, CNS involvement. As far as the neurological involvement is concerned, it can cause so many features, but some important points for exams are important. Defective cognition, reduced cognitive function, and neurocognitive dysfunction is the most common feature as far as systemic lupus erythematosus is concerned. And this defective cognition is associated with one important antibody that is called as anti-NMDA receptor antibody. Remember, anti-NMDA receptor antibody itself alone can cause encephalitis. That's called anti-NMDA receptor antibody encephalitis. That's different. But SLE patients also can generate this anti-NMDA receptor antibodies, which is otherwise referred to as anti-glutamate antibodies. Because NMDA receptor is basically glutamate only, anti-glutamate antibodies. Clear? So that happens in the setting of SLE. That is due to defective cognition. And patients with SLE can develop stroke also. And one of the important reasons for stroke is thrombus formation. One of the important reasons for thrombus formation is APLA antibodies, antiphospholipid antibodies. They can produce thrombus and stroke subsequently. And you can get behavioral problems in SLE. Behavioral means I'm talking about psychosis and depression. And psychosis and depression SLE is typically associated with an antibody called as anti-ribosomal protein antibody. Very important question exam. Behavioral problems in SLE. Psychosis and depression. Anti-ribosomal protein antibody. Anti-ribosomal P antibody. Then there are some diffuse manifestations in SLE. Diffuse neurological manifestations like headache, seizures, and all this stuff. And this is due to presence of certain antibodies called anti-neuronal antibodies. That has a good correlation with that. And the patients can develop transverse myelitis. LETM-like picture, longitudinal extensive transverse myelitis-like picture, otherwise referred to as NMO spectrum disorder. I can simply write as NMOST. So, I mean, NMO is a separate disease that's associated with neuromyelitis optica antibody, NMO IgG. We saw that's anti-acoparin 4 antibody. But here, many other conditions can produce a picture similar to that of NMO, called as NMO spectrum disorder. And in SLE, NMO spectrum disorder-like presentation is associated with anti-Rho antibody. That is always called as anti-SSA antibody. Apart from that, SLE patients can have vasculitis, CNS vasculitis. SLE patients, apart from that, can have peripheral neuropathy also. Neurological manifestations of SLE. So in that, the impaired cognition is going to be the most common picture. The defective cognition, most common. They can develop stroke, behavioral problems, diffuse neurological manifestations like headache, seizures, and NMO spectrum disorders, CNS vasculitis, peripheral neuropathy. All these things are possible in a patient with systemic lupus erythematosus. Don't forget headache. Headache is also one of the very, very important, neurological manifestation of SLE, which will come under diffuse manifestation. And they can have ocular involvement, eye involvement in SLE. Of course, when you take a eye involvement SLE, again, the keratoconjunctivitis sicca, the dry eyes, the sicca syndrome is going to be the most common. Like rheumatoid arthritis, sicca is the most common. They can result in retinal vasculopathy, causing impaired vision, reduced visual acuity, and that's the second most common. And this retinal vasculopathy in systemic lupus erythematosus manifests like cotton wool spots. They can develop cotton wool spots in this setting. Then, apart from that, they can have hematological involvement, blood involvement, that is hematological involvement. Most common hematological manifestation of SLE is, of course, going to be the anemia. And there are many reasons for anemia. One is anemia of chronic disease. It can happen in any chronic disease. And second is hemolytic anemia, because SLE is a condition that can produce, antibodies that produce hemolysis. So in that, if they ask you commonest form of anemia, of course, most common hematological manifestation anemia, the most common form is AOCD, that is anemia of chronic disease. Hemolytic anemia can happen, and it is associated with an antibody called as anti-erythrocyte antibody. Anti-erythrocyte antibodies can produce anemia of chronic disease. But nevertheless, typically they will have a NCNC type of anemia only. That is normocytic, normochromic type of anemia. Later on, they might have a microcytic hypochromic type, but typically they tend to have a normocytic, normochromic anemia. You know very well, anemia of chronic disease patients will have reduced reticulocyte count, normal lactate reactogenase. But whereas hemolytic anemia patients will have an increased retic count and they will have an increased LDH. Both can be normocytic, normochromic anemia. That's very important. Reduce retic count and increase retic count. Very important difference as far as the hemolytic anemia is concerned. Since it's an immune-mediated hemolytic anemia, typically direct Coombs test will be positive, but here DCT will be negative. So you can easily differentiate these two types of anemia that happens in SLE. Hemolytic anemia, because this hemolytic anemia is immune-mediated. Clear, it's because of antibodies. So definitely they will have a DCT positivity. Whereas this anemia of Crohn's disease will not have any DCT positivity. And you should surely do direct Coombs test. Whenever you see an anemia in SLE patient, you should definitely do direct Coombs test. It's a very, very important test. That's the one that's going to differentiate your hemolytic anemia from other causes. And other manifestations in SLE include leukopenia, very common. In general, more than leukopenia, there will be lymphopenia in these patients. Lymphopenia in these patients. Usually, the lymphocyte count, if you take the absolute lymphocyte count, it can be less than 1,500 as far as the lymphocytic count is concerned. And neutropenia is not a very common finding. Neutropenia is actually a rare finding in the setting of a systemic lupus erythematosus. And they can have thrombocytopenia also, low platelets. And usually the reason for thrombocytopenia will be ITP. And this ITP is actually secondary ITP, not a primary. We have two types of ITP, primary and secondary ITP. Primary is idiopathic. Secondary ITP, one of the causes of secondary ITP is your immune-mediated mechanism. Just hold on. I'll just restart the session, 2 minutes.